بسم الله الرحمن الرحيم. I am Dr. Muayyad, internal medicine specialist, BLS and ACLS instructor. I am going to give lecture today about cardiac arrest. This lecture very important for who is preparing to go to the ACLS course. Objectives: cardiac arrest rhythms and cardiac arrest algorithm. So in this lecture, we review the cardiac arrest rhythms divided two groups: shockable rhythms and non-shockable rhythms. Then we'll review the algorithm for the cardiac arrest according to the American Heart Association 2020. Cardiac arrest rhythms. We'll divide it to groups: shockable rhythms, non-shockable rhythms. Shockable, that means if patient has these rhythms, he need DC shock. But if there is this rhythm, no need to give the patient DC shock, no benefit from the DC shock. So, shockable rhythms, either ventricular fibrillation or pulseless ventricular tachycardia. If we have patient, he has cardiac arrest, CPR ongoing, then defibrillator available. So we'll attach patient to the defibrillator. Then we will see the rhythm. If there is VF or pulseless VTAC, so patient need DC shock. Okay? But if there is asystole or pulseless electrical activity, so no benefit from the DC shock. Let us review the rhythms one by one. VF. VF, it is chaotic irregular deflections of varying amplitude. In this rhythm, no B waves, no QRS complexes, no T waves. It is chaotic rhythms. The rate between 300, 400, up to 500. It is actually not clear because no QRS complex. Amplitude usually decreases with time from course VF to fine VF. I will give you example. If patient has MI, myocardial infarction, then he developed cardiac arrest because of VF. Usually, the VF will be coarse at the beginning. Then, with time, we'll go to the fine VF. Then, asystole, if no management. Okay? We'll start with coarse, then fine, then asystole. Coarse VF, when I will say the patient has coarse VF, when the majority of the waveform measure 3 millimeter or greater. So most of the waves more than 3 millimeter. The amplitude of the waves more than 3 millimeter. But I will say this, fine VF when a majority of the waveform measure less than 3 millimeter. The rate not measurable between 300, 500. Okay? Because no QRS, no B wave, no T waves. Rhythm irregular, no B wave, no BR interval, no QRS complex. What this rhythm? It is chaotic, wave, amplitude. Let us see this wave. From here up to here 5 millimeter, up to here 10 millimeter. So this is amplitude about 12 millimeter. This one about 12. Here more than maybe 7 millimeter. Okay, this is coarse VF because the majority of the waves more than 3 millimeter. As I said, usually patient will start with coarse VF. With the time, if no proper management, we'll go to the fine VF here, like here. Then we'll go flat line or asystole. Okay, this is fine VF. The majority of the waves less than 3 millimeter. Maybe some wave like here, like 3.5 millimeter, okay? But most of the waves, the amplitude of the waves less than 3 millimeter. So this is fine VF and this is coarse VF. Then I will discuss with you the ventricular tachycardia. If there is on the monitor ventricular tachycardia, ventricular tachycardia can be monomorphic VTach, can be polymorphic VTach. Okay? If there is pulse, then we will go to the tachycardia algorithm. But if there is no pulse, that means patient has cardiac arrest and patient need CPR, high quality CPR, and need DC shock because this is shockable rhythm. So let us review the monomorphic ventricular tachycardia. VTach is a broad complex tachycardia originating in the ventricles. Monomorphic ventricular tachycardia originates from a single focus within the ventricles. So will give us the same shape for the QRS complex. Okay, produces uniform QRS complex within each lead because coming from one focus, single focus, so the shape will be similar, same shape. Except sometimes there is fusion beats or capture beats. I will not talk about this beat now, maybe another lecture. So monomorphic ventricular tachycardia, the rate will be more than 100. The rhythm will be regular. No B wave, no BR interval because no B wave. The rhythm originated from where? From the ventricles. A QRS complex, wide, more than 120 milliseconds. 120 milliseconds, that means more than three squares, small squares. Okay, more than 3 small squares. So the QRS is wide. As I said, monomorphic ventricular tachycardia. With pulse, we will go to the tachycardia algorithm. But if no pulse, that means patient has cardiac arrest and patient need CPR and need DC shock. And we will follow the algorithm of the cardiac arrest. If I see this rhythm on the monitor, I will say this is ventricular tachycardia. This one also same, ventricular tachycardia. Look, same shape for the QRS. No B wave, no BR interval because no B wave. Why the QRS? wide QRS. But if there is no pulse, so this is will be pulseless ventricular tachycardia. Pulseless ventricular tachycardia. But if there is pulse, will not patient no need CPR because there is pulse. So how will treat the patient with pulse? We'll go to the this is tachycardia algorithm. If there is no pulse, we'll go to the cardiac arrest algorithm. Is it clear? Very important this point. With pulse, we'll go to the tachycardia algorithm. No pulse, cardiac arrest algorithm. What about polymorphic ventricular tachycardia? Polymorphic ventricular tachycardia is a form of VTAC in which there are multiple ventricular foci with the resultant QRS complexes varying in amplitude, axis, and duration. This one, polymorphic ventricular tachycardia, the shape of the QRS not same. Look, this QRS, this one, not same this one, not same this one. It is different. Okay? The shape not same. The rate more than 100 because we are talking about tachycardia. The rhythm irregular. No B wave. So no B wave, we cannot talk about BR interval. A QRS complex is wide, more than 120 milliseconds. That means more than 3 small squares. This is polymorphic ventricular tachycardia. If no pulse, we will go to the cardiac arrest algorithm. What about torsades de points? Or in French, torsade de bois. This torsade de points is a specific form of polymorphic ventricular tachycardia. Here, what is the problem also? There is a QT prolongation. It has a characteristic morphology in which the QRS complexes twist around the isoelectric line. So twisting of the points. Look here, the waves, up, down, up, down. See, this is torsade de point and wide QRS. So the patient should have polymorphic ventricular tachycardia, plus there is evidence of QT prolongation. So this is the torsade de points. The rate between 200 to 50 beat per minute, between 200 to 50 beat per minute. Rhythm irregular, B wave none, so we cannot see the B wave here. BR interval also because no B wave, no BR interval. QRS complex wide, more than 120 milliseconds. That means more than 3 small squares. The management of the torsade de points, this is like polymorphic ventricular tachycardia. Patient, if no pulse, will start CPR and DC shock according to the algorithm of the cardiac arrest. But here also we can give the magnesium sulfate 1 to 2 gram. Now, what about pulseless electrical activity? Actually, this one not a rhythm, but this one a group of rhythms. So any organized rhythm without a pulse is defined as pulseless electrical activity, PEA. Maybe on the monitor, sinus rhythm, but no pulse. So I will say this is pulseless electrical activity. He need CPR. So there is electrical activity but no ventricular contraction. That means there is cardiac arrest. No cardiac output. No ventricular contraction. That means no cardiac output. This rhythm, non-shockable. No need to give the patient DC shock because no benefit from the DC shock. More important, high quality CPR and medication. If this rhythm on the monitor, there is QRS, okay? There is QRS, but when I check the pulse, no pulse. So this is pulseless electrical activity. The rhythm may be regular, may be irregular, maybe sinus rhythm, maybe sinus like sinus tachycardia, maybe like sinus bradycardia, maybe AF, maybe supraventricular tachycardia, but when I will check the pulse, no pulse, so I will say this is pulseless electrical activity. So the rate may be fast, may be slow. The QRS may be narrow, may be wide, maybe there is B wave, maybe no B wave. The more important, organized rhythm, but no pulse. So this is pulseless electrical activity, BEA, and patient need what? Need high quality CPR and medication. Don't forget to treat reversible causes. Asystole. Asystole, no electrical activity on the ECG. So what I will see? Flat line, no waves, no B wave, no QRS, no T wave, nothing. It is flat line. Actually, flat line is not a diagnosis. So the diagnosis asystole. When I will see this rhythm on the monitor, so quickly I should rule out any other causes of an isoelectric ECG. Like what? Like loose leads. Actually, old machine, if there is loose lead, will give me flat line. But the new machine now will not give flat line like this, will give dots line. Dots line. If I see this dots line on the monitor, that means there is loose lead. I will ask somebody to see the leads connected correctly or not. If there is no power or signal gain, I should check it to rule out any problem in the signal gain. Maybe the amplitude very low, so I should increase it, because maybe sometimes flat line there is wave but very small, I cannot see on the monitor. I will think maybe this is asystole, so I should check the signal gain, okay, to rule out the amplitude may be very low. Asystole is non-shockable rhythm, so no need to give DC shock for asystole. High quality CPR, very important, and medication. For non-shockable rhythm, medication, adrenaline, as soon as possible, give adrenaline. This is the adult cardiac arrest algorithm, American Heart Association 2020. If patient has cardiac arrest, what I will do for the patient? First of all, start CPR, high quality CPR. Give oxygen, attach patient to the monitor defibrillator. Then I will look for the monitor. As I said, I will divide the rhythm to the two groups. Shockable rhythm, I will go through this pathway here. If non-shockable rhythm, I will go through this pathway. So If there is on the monitor VF or pulseless ventricular tachycardia, I will continue high quality CPR. Then I will give DC shock as soon as possible. Okay, so high quality CPR and shock. And I will try to get IV. If there is no IV available and we cannot insert IV, then we can try IO, Acls. So this is first 2 minutes high quality CPR and DC shock and IV Acls. After 2 minutes pass. So what I will do? Always after 2 minutes, I should stop CPR, switch the compressor, and analyze the rhythm. After 2 minutes, finish, stop, switch, analyze. Then I will check the rhythm. If it's still shockable rhythm, that means still need DC shock. I will let them to continue high quality CPR and to give DC shock. So this will be the second shock. Okay, second shock. Then here what I will give after second shock, I will give epinephrine. This will be first dose. Epinephrine, I will give epinephrine or adrenaline after the second shock. Then when I will repeat the epinephrine, adrenaline, I will repeat every 3 to 5 minutes. Let us say 4 minutes. Okay, so if in this cycle I gave adrenaline, next cycle I will not give adrenaline. It will be alternative cycle. One cycle we will give adrenaline, next cycle we will not give. Then again we will give adrenaline. Because we will repeat it every 3 to 5 minutes. Okay, so it will be alternative cycle. Here also we can consider advanced airway. And if we intubate the patient, don't forget to attach the capnography, waveform capnography. Okay? Then if 2 minutes this cycle finish, 2 minutes finish, stop, switch, analyze. If it's still shockable rhythm, what you will do? Resume CPR immediately and prepare to give the third shock. Okay? So 1 shock, 2, and 3. This is the third shock. After third shock, you will give amiodarone or lidocaine. Amiodarone, the dose will be first dose 300 milligram. Lidocaine, we can give 100 milligram for the adults. Okay, don't forget to treat the reversible causes. Always search for the reversible causes and try to treat it. So after second shock we will give epinephrine. After third shock we will give amiodarone 300 milligram. Then this cycle finish, 2 minutes pass, then stop, switch, analyze. If it's still shockable rhythm, again give DC shock. After DC shock, here what you will give? Now adrenaline due. So you will give adrenaline 1 milligram. No need amiodarone after here, because amiodarone will repeat after 3 to 5 minutes. So adrenaline given, then stop, switch, analyze. Still shockable rhythm, give DC shock, then give amiodarone 150 milligram. Okay, we'll continue like this. For amiodarone, we'll give 2 doses. First dose 300 milligram after third shock. Then next cycle, no need to give amiodarone. Then after that, the other cycle you will give amiodarone 150. I am talking if still shockable rhythm all this time, still when I stop, switch, analyze the rhythm, there is shockable rhythm. But if any time non-shockable rhythm, we'll go to this pathway. or if from the beginning non-shockable rhythm, will go to this pathway also. So now if in the monitor there is asystole or pulseless electrical activity, how I will manage the patient? High quality CPR and give adrenaline as soon as possible. So epinephrine, first dose will be in first cycle. As soon as possible, give epinephrine for non-shockable rhythm. For shockable rhythm, epinephrine will be after the second shock. But for non-shockable rhythm, epinephrine will be as soon as possible. So from the first cycle, try to get IV. If not available or you cannot insert IV, then try IO axis. Then epinephrine, as soon as possible, this is the first dose. Then we will repeat it every 3 to 5 minutes. For advanced airway, if you insert ET tube, then consider attach the capnography if available. Okay? Also here, after 2 minutes, stop, switch, analyze. Analyze the rhythm. If still non-shockable rhythm, continue high quality CPR. For medication, as I said, epinephrine will repeat every 3 to 5 minutes. Don't forget to treat reversible causes. If any time coming shockable rhythm, then go to this pathway. This is the way how to deal with cardiac arrest patient. For CPR quality, let us review. This is small here. We will go to the another slide. Here, I will not talk today about the high quality CPR and like this, just we will mention it to have idea, because this one need another lecture. Anyway, CPR quality, that means high quality CPR. What we should do, push hard, at least 2 inches, 5 centimeters, and fast from 100 to 120 per minute, and allow complete chest recoil. Minimize interruption in the compressions. So any interruption should be less than 10 seconds. Avoid excessive ventilation. Very, very important. As I said, I will not talk today about the high quality CPR and why all these things. Maybe another lecture. Change compressor every 2 minutes or sooner if fatigued. If no advanced airway, so you will give 30 compression to a breath. The ratio will be 30 to 2. 30 compression to ventilation. Waveform capnography, very important. If end tidal CO2 low, less than 10 millimeter mercury, so encourage your team to for high quality CPR. For shock, according to your machine, defibrillator, biphasic or monophasic. For monophasic, you will start by 360, continue 360 all the shock. For biphasic, now most of the machine now biphasic. A new machine biphasic. The energy for the DC shock from 120 to 200. But if you don't know the machine and what the recommended dose, then go to the higher dose available. For drug, epinephrine or adrenaline, will give 1 milligram every 3 to 5 minutes. As I said, first dose for shockable rhythm will be after the second DC shock. First dose for the non-shockable rhythm as soon as possible. Then we'll repeat every 3 to 5 minutes. For amiodarone, first dose 300 milligram. This will be after third DC shock. Then after that, the second shock, the dose will be 150. We will repeat this dose after 3 to 5 minutes from the first dose. For lidocaine, first dose will be 1 to 1.5 milligram per kg. If I have patient like 70, 80 kg, I can give 100 milligram. Then the second dose, I will repeat like 50 milligram. For advanced airway, endotracheal intubation or supraglottic advanced airway, then I will attach the waveform capnography to confirm and monitor the ET tube placement. But here, once advanced airway in place, so I will give one breath every 6 seconds. So will be 10 breaths per minute with continuous chest compressions. So here, if patient intubated, no more synchronization between the chest compression and ventilation. Chest compression will be continuous at the rate of 100 to 120, and the breathing, the ventilation will be one breath every 6 seconds. What is ROSC? Return of spontaneous circulation. If there is pulse and blood pressure, that means we get ROSC. Or if suddenly this is an increase in the end-tidal CO2, typically more than 40 millimeter mercury, and continue like this, so I get ROSC. Or if there is blood pressure, if there is intra-arterial line, there is arterial line for the patient, and I'm monitoring the blood pressure through the arterial line. If there is blood pressure, so I get the ROSC, return of spontaneous circulation. What about the reversible causes? Also, this one need another lecture. Maybe when we will talk about systematic approach, we'll talk about this one. Anyway, for when there is CPR for the patient, always don't forget to search for the reversible causes like hypovolemia, hypoxia, hydrogen ion acidosis, hyperkalemia, hypothermia. It is also tension pneumothorax, tamponade cardiac, toxins, thrombosis pulmonary, thrombosis coronary. So this one need another lecture, reversible causes. Okay, always don't forget to search for the reversible causes. Thank you.